Very good morning, Dr. Milinkiri. First of all, thank you so much for taking time to come out and attend this CAR-T Summit, which is the first of its kind in India. When you select a patient, when you think the patient is eligible for CAR-T, and if you want to guide someone who is doing a CAR-T for the first time, how we do suggest him depending on patient selection and then apheresis and subsequent vein-to-vein.
If you're going to talk about the CD19 CAR-Ts, which are for lymphomas and B lymphoblastic leukemias, well, for the lymphomas, I feel the patient has to be it has to be somebody who is relapsed. You cannot use it for upfront therapy just because it's available. It was still indicated for somebody who is not responding to initial treatment or who has relapsed following his initial treatment, and there is no other simpler or cheaper option available. Then with a curative intention in mind, you're going to do a CAR-T cell therapy. So it's important to note that you have to have minimum disease burden for the CAR-T to work. You can't expect somebody to have a large disease burden and you just infuse the CAR-Ts and it's going to work. That's not going to happen. So you need to first get the disease burden down. You would either use some sort of a salvage chemotherapy or other immunotherapy drugs which are not going to hamper the T lymphocytes, which are your cell, the cells that you're going to extract and create CAR-Ts from. If you don't want to harm those cells, and therefore you would give treatments that would get the disease burden down without touching the T lymphocytes so much. And once that is done and your disease burden is low, you can go in for CAR-T. Otherwise, if the disease burden isn't too much, you would decide to extract harvest the lymphocytes, send them for CAR-T production, and then give you a bridging therapy, and then take up with the patient for the CAR-T cell therapy. There are certain drugs that we know is that cannot be used before doing a CAR-T cell therapy. After this is, once you've decided to do the apheresis, there is a certain wash-off period which would be required after your last treatment, and then you decide to send the cells. The cell, ImmunoACT has done a great job in that they have a third party which will collect these cells, and they would send it to the ImmunoACT lab, and that is done in dry ice. It takes roughly about 2 weeks. During this 2 weeks time, if you feel that the disease burden is going to increase, you need to give a bridging therapy. Once the disease is at its minimum, you need to infuse the CAR-T cells. Logistics are taken care of well by ImmunoACT, I must say, and we are very happy about that, because we don't have to get into the stress of making sure that the cells are going appropriate to the center and they're coming back in the correct states. That's never been a problem for us. When they're infused, we generally typically keep the patients in the hospital for about a week or 10 days and handle all the complications, cytokine release, etc., infections. And once the patient is out of that period, we generally discharge them home, and then subsequently it's monthly follow-ups, monthly monitoring of parameters to make sure that his immunoglobulin levels are well maintained. And so about 6 months is the time you need to take care of the patient. Subsequently, they're good.
So if I want to break it up for someone who is taking a patient for CAR-T cell therapy for the first time, first you need to ensure a better patient selection, one who is having a low disease burden, relapsed or refractory cases of CD19 positive B ALL or B non-Hodgkin's lymphoma. Once a patient selection is done, once a counseling of the patient is done, you need to contact someone from the ImmunoACT team, preferably the zonal manager who would be visiting you from time to time. After that, you'll be given a link to a patient information form in which we ask the basic details of the patient regarding patient identification and the prior lines of therapy received. Following which, we would be having a clinical discussion with the consultant with respect to the selection of best date for apheresis depending on washout period of the therapies that the patient has received. Once a slot is allotted, that date is blocked for that particular patient from our end for the manufacturing. On the day of apheresis, A team member from ImmunoACT will be present at your center for any support that would be required, and the clinical team will also be in touch with you over telephonically. A virtual clinical orientation session will also be held for your clinical staff, the transfusion medicine and the nursing team, so that we ensure that your team is very well trained and geared up to handle the patient of CAR T-cell therapy. After apheresis, the protocol of apheresis is not greatly different from stem cell collection. The apheresis is done at the center. The product is picked up by a third-party logistic partner, the responsibility of which again lies with ImmunoACT. It is picked up at 2 to 8 degrees Celsius and it is shipped to Navi Mumbai, which is where in Rabale we have our manufacturing GMP facility. Following which, first we will be checking the CD3 count of the patient, of the bag that we have received, and we will be communicating with the consultant whether or not that is adequate to begin manufacturing. In rare cases, if CD3 count is not adequate, we may require the consultant to do a second set of apheresis. Once the CD3 count is confirmed and we have begun manufacturing, the consultant can proceed to give any bridging therapy which the clinician may wish to do. From our end, this will be followed by steps of lentiviral CD3 count selection, activation, monocyte separation, lentiviral transduction, and following which the transduced CAR T cells will be left for expansion anywhere between day 6 to day 9. When we achieve a dose of more than 5 million CAR T cells per kg, the harvest that will be collected, the final product will be cryopreserved, and the next 10 days will go for QC testing. So it will take roughly 19 to 20 days for the product to be manufactured and run all the QC tests, following which it will be shipped back to you at -80 degrees Celsius with dry ice. At the time of infusion as well, one of our team members may be present with you for any support that is required. Prior to infusion of CAR T-cell therapy, you would have to give lymphodepletion. Most commonly used regimen between fludarabine and cyclophosphamide on day -5, -4 and -3. Followed by a rest of 2 days to maximum 7 days, and then you can proceed to infuse the patient after thawing the product, the same way you would infuse your stem cell collection. And the last question to you, sir, do you face any particular challenges while counseling the patient with respect to patient awareness, patient's understanding, and the finances, of course?
Yeah, the concept is easy to explain to the patient, and the good thing is that patients are very excited when they listen to this kind of a novel treatment that's going on, that you're going to actually extract lymphocytes, the natural killer cells of cancers. You're going to actually genetically change their genes and make them and expand them and then send them back to kill the cancer cells. So that concept is very exciting for patients, and patients are very, very happy when they're intrigued by that such a treatment is available. The challenge is, of course, the cost, which needs to be, which is high, of course, and that's the way it is until for the next few years. I hope the costs come down in future. The other challenges is, when you talk to them about patients want cure. So to tell them that an expensive treatment is not going to give 100% chance of cure, then that is the only challenge. And the other challenge is that you can't tell them which patient is likely to be cured. Right. So it's very unpredictable. Just like a transplant, you don't know which patient is going to be cured. Similarly, in CAR T, you can't predict that, and that's where the uncertainty is. That's the only challenge. But then all said and done, I would say majority of patients are excited and they want to go in for this treatment.
Do you think if we can better strategize the bridging or better strategize addition of some maintenance or any combination approach that could enhance the responses to CAR T-cell therapy, and we can think of cure of a patient if the ideal or the best combinatorial approach is applied? Currently,
I think that is something which we really need to know, and I think forums like this that you've organized, wherein consultants who've tried out all these kind of treatments, that experience sharing, that data collection in future is something which is of utmost importance, and it is really required, because everybody is going to infuse the CAR T cells, but how to best to treat them before the CAR T and after the CAR T in order to achieve that goal of cure is, I think, very important.
Thank you, sir.